But do you want me to say more about this?
So we can just pause there for a little bit and then we can go from there. So what I heard, Abea, is she's a 35-year-old who's coming in with blood in her urine, correct?
Correct.
All right. So that's kind of a good place to just pause and start when we hear about bloody urine. You always want to make sure you're not getting fooled by a mimicker of it. So I always take a pause there. I'm like, okay, if it's a blood in the urine, could it be from vaginal bleeding? Something to consider about, or in some older people that have incontinence, bowel or bladder, is that a hematuria that we're dealing with? But if we just kind of say like, hey, we're pretty sure this is blood in the urine, and if she's already seeing the blood, I'm more worried about like a gross hematuria rather than like microscopic hematuria, which is kind of like blood in the urine. And just like anything else, you kind of want to localize where the issue is there a systemic issue with a bleeding disorder that is presenting as blood in the urine. So if someone is like on anticoagulation, or someone has like any causes of like congenital or acquired bleeding diathesis that is presenting that way, or are we dealing for more of a localized issue to the genitourinary tract, whether sometimes infections can present with hematuria, stones, or trauma to any aspect of it, masses. So the diagnosis is quite wide. So the first thing is like, let's make sure it's the blood in the urine and get some time frame, and also to see where we can localize it. All right, Bea, do you want to tell us some more?
Amazing reasoning. So this blood in the urine began 2 days prior, and there were no blood clots. The patient complained about being fatigued and dizzy for the past 2 weeks, but she didn't have any fever, nor pain, nor other symptoms.
Okay, so she's just having some with pain with some urination that started about 2 days ago. The things that makes me a little worried about, she's also complaining a little bit of like dizziness, sounds like it, that started about the same time frame. So the question, because is that dizziness because she's just losing so much blood? And that's why she is dizzy. Whenever I think about like acute anemia or blood loss, the places that you want to think about that you can lose that much blood in is definitely gross hematuria can do it. Through your GI tract can do it. You can like hide blood in your retroperitoneum, in your thighs, and also in your thorax are kind of like the places I think about the blood can go. So if somebody's coming in with dizziness plus gross hematuria, then again, I want to make sure, if they're bleeding into their urine, they're not bleeding anywhere else that is causing the dizziness. And the other thing that would be helpful is to kind of get a sense of the amount of it that is going on. And, I don't hear anything about like fevers or any signs of inflammation just yet. And it kind of sounds that it's been quite painful with no preceding trauma. So I think kind of for the next step, this is someone that it would be really helpful, to get some more information about like if they have any past medical history from any medications, like anticoagulations, that would make it bleeding worse. And the other thing, with a 35-year-old, again, making sure we're not dealing about a vaginal source, especially, with like thinking about like pregnancy losses, miscarriages, any uterine source of bleeding, because they can be also pretty severe. So those are the things that I was in my mind, and while we hear more from Bea.
I'm just so impressed by the amount of things you've already said. And I'm afraid I won't be helping you very much with the next analysis, because looking the past medical, surgical, and social history. She denied having medical history, any past medical history. She did not have any surgery performed, no medication at the moment. And regarding tobacco, she denied tobacco use or drug use. And do you want me to say more about the general exam, the physical exam? Yeah, because
that's really great.
so again, we found she was dizzy, as we said, but looking more at the vital sign, she had a temperature of 36 degrees. Heart rate was 57, respiratory rate 16, blood pressure 130/80, saturation 98%. She had no palpitations, so cardiovascular system was normal, and hearing her lungs was clear to auscultation, so no wheezes, nor crackles or bronchi. Her abdomen was soft, non-tender, non-distended, and she did report fatigue and dizziness, but she didn't have any altered level of consciousness. And looking at her skin, she didn't have any purpura nor petechiae nor anything else.
Thanks so much, Bear. And just to make sure I heard that right, the heart rate was in the 70s?
No, 56.
56. Huh.
Yeah.
All right. So kind of, as you mentioned, in terms of like the past medical history, nothing really that jumps out. And one thing that, I always say, just because we haven't seen it, it doesn't mean the patient doesn't have it. A lot of the time, especially with the younger adults, like they don't present to care as much, and some of the chronic diseases just have to manifest somewhere. So just because it's empty doesn't mean we should just say completely healthy from that perspective. In terms of the vital signs, the heart rate of the 50s, if someone is endorsing some amount of like dizziness and lightheadedness, it's a lower than I would think in that setting. However, one thing to note is like this patient is sitting, and if you're worried about the blood loss causing her symptoms of dizziness, then it's most likely in a setting of orthostasis. So with the orthostasis in general, this is someone that I would, if you're seeing them in the emergency room or in clinic, like do some orthostatic vital signs. I'd be curious to see if that is the source of the lightheadedness, because that's another problem we're trying to solve right now. In my mind, they might be related to each other. Does bleeding plus the dizziness. However, we want to make sure we're not separate. The dizziness is actually orthostasis, as that's how they would relate to each other. And that would give you some clue. In terms of the rest of the exam, is like pretty unremarkable, nothing that jumps out to us. I mean, the fact that an abdominal exam is like completely benign is reassuring. It tells us it has time. I really loved they are mentioning the skin exam, because while like, gross hematuria, a lot of the times we think about acute bleeding, we want to think about like, other etiologies as well. They tend to be mostly microscopic in nature, but like glomerular pathologies, like vasculitides that present that way, looking for petechiae, if there's a platelet dysfunction, vasculitides looking for palpable purpura, and then petechiae with platelets dysfunctions, which kind of seems like she doesn't have it. The other thing that I often look for in someone who's like presenting with some concerns for bleeding is, easy bruising, asking about like gingival type of, like when they're brushing their teeth, how long does it take for, if they like have a scrape for the bleeding to stop. So some of those things can help whether, again, distinguish whether this is like a generalized problem or more localized to what we think is genitourinary with question of like vaginal bleeding so far. All right. I'm excited to hear more.
Again, I'm very much impressed by the amount of things you just said. So, regarding the labs, the urine analysis, again, we saw an important amount of blood, in particular, red blood cells were 115, protein was 300, and white blood cell count was 24. Leukocyte esterase was positive, nitrites were positive, but the culture was negative. And regarding the blood count cells, so the white blood count cells was 7.9 K, hemoglobin was 14, red blood cells was 4.24, MCV was 92, and the platelet count was 8,000. Do you want me to say more?
Oh, wow. What? So she has like thrombocytopenia, correct? Just want to make sure.
Yeah, correct.
Okay. Well, now it gets even more exciting. We can maybe pause here and then give us some more information. So in terms of like the UA, again, now we just know that this is like some gross hematuria that she is having. And, in terms of like the Luke esterase and the nitrates being positive, it's a little odd. The question that I have that I actually don't know the answer to this right now is that if you're having a lot of red blood, are those markers still accurate, or kind of like, the amount of blood that is there kind of messes up with the assay? However, she's not really having any symptoms of urinary tract infection. I was recently just talking to my team about like how hard it is sometimes to actually diagnose urinary tract infection. I thought it would be so simple, but it's actually more complicated. And as someone who has no symptoms of UTI, I'm the culture that is not growing anything, I would probably just hold off on calling this an infection and treating her. So then the question is like, okay, if this is not a UTI causing it, what else is going on? Then we have thrombocytopenia. So now we have a reason as to her propensity to bleed. However, why only is this showcasing in the urine? So the question is like, does she have any anatomic abnormality that is making her bleed more? So thinking about masses, thinking about any trauma. So that is still what we need to like get a better idea of her urinary tract system. And I wonder like if a CT urogram or something would be appropriate at this point. Then let's focus on the thrombocytopenia. With the thrombocytopenia, and it's an isolated thrombocytopenia. So then the question becomes like, hey, is this destruction issues? Is this something in the environment of the platelets that can cause a destruction? Is it or a bone marrow issue? There are a lot of like the thrombocytopenias that kind of like my schema for that. The two things that I first think of, like that I don't want to miss, is that if there's any schistocytes as well, and if we are dealing with actually a picture that is more microangiopathic hemolytic anemias, however, hemoglobin of 14, I would still send a smear. It's a little less likely. And then the other one that I always like think about is HITs. So a lot of the time in the hospital, people can get heparin re-exposures, and they can have isolated thrombocytopenia with like usually more clotting than anything else. But so those are the two big things that I first think of. And, she's young, she's been out of care, so this is less likely to be hits or kind of not the clinical picture that you would see for MAHAs. So then the question becomes like, is there anything else in the environment of this, the platelets? And oftentimes in the hospitals, that's like, people, the things we do to people, like a CVVH, like which is a continuous like hemodialysis when they're sick. They're like, if they're like sick in the ICU and they have balloon pops, so any external factor that causes shearing of platelets, that again, we don't think that is, that's not this person. Then it becomes an issue of, are we dealing with, I think about like bleeding and thrombocytopenia, which is like ITP. And, ITPs can be either primary or secondary. And a lot of the times when the isolated thrombocytopenia is that low, like ITP is most often the one that we think the most about. However, it is the remaining is diagnosis of exclusion. Then we think about like things that can get inside a platelet that can cause problems like a whole slew of infection, as well as being sepsis, toxins. However, those things tend to become more bicytopenia and pancytopenia as goes along. So I'm worried about ITP in her. And I'm also, the second question I'm asking myself is like, why is the blood coming out of the urine specifically? So, some getting our urologist input here would be really informative as well. Cool. All right, I talked a lot.
You did talk a lot, but the answer is somewhere in what you said. So
I'm on the right track.
Yes, somehow, but it's not that easy. Anyway, so we had the glucose that was high, 120. Sodium, potassium chloride, calcium were normal, and CO2 was low. It was 14, and AST, ALT were normal. But the total bilirubin, as someone has asked, was slightly high, was a 2.5 milligram per deciliter, and the PT and PTT were normal. If you want, I can say more.
So just to make sure I grabbed all of the abnormalities. So the T-billy was a little high. Do you have like the direct component of it?
No, just the total.
The total. Okay, no worries. All right.
Okay,
cool. Do you want to give us a little bit more information then?
Yeah, of course. So we did some radiology, a CT and pelvis was asked, and there was some fluid-filled loop for bowel, but for the rest was normal, so no acute abnormality. Some additional labs were asked, in particular the peripheral smear, and they found schistocyte, spherocytes, and abnormal RBC. I'll stop there.
All right, the blood thickens. So, you should never with confidence say it's not MAHA until you get some more information. But so kind of looking about it, the the hyperbilirubinemia grabbed my attention. And, oftentimes with whatever we think caused destruction of platelets or the RBCs, we think about indirect hyperbilirubinemia because, again, the cells burst, and then the bili is in the indirect form. And then we have schistocytes. So it's always good to hold our breath when there's a schistocytes and think really rapidly about them. Oftentimes, people can have one or two schistocytes here and there. However, in the correct context, you want to worry about the schistocytes. And the schistocytes, the things that often we think about is like microangiopathic hemolytic anemias. We think about DIC, TTP, and HUS. as often with that. Interesting enough, I often don't see platelets this low with the MAHAs. With DIC, the fact that the like the coagulation cascade seems to be normal, it points me a little bit against a DIC being the etiology of it, and DIC is often secondary to something. Again, we can't completely say like getting a fibrinogen and all your other factors would be helpful. And then when it comes to HUS and TTP, like it would be helpful to know, and I think Yusuf put that in the chat as well, is that was there any history of diarrhea? Are we worried about like, E. coli being in the hook for HUS? So I think we are in, the right now in the world of MAHAs and needing to explore that a little bit more. So when we think about MAHAs, sometimes like, Adams 13 is, if I remember correctly, that's the one thing that we want to send out, but tends to be a clinical diagnosis. With the creatinine that is fine, often kidneys are in the hook, which I don't see that, or, the nervous system, which is not altered either. But that is what I would worry about in this setting, in addition to, again, getting a sense of like why she's having a gross hematuria. With the kidney findings, HUS is a little bit more likely, but, gotta have a little bit more information. What were you thinking, Bea?
So we were thinking as you mentioned that to MAHA or MAHA, and as you said, she was fine, like looking at her urinary tract and the kidney, how everything was functioning. We were also thinking she might have been exposed to HIV or HCV, but the tests were negative. However, we did the DAT and that came back positive. And do you want me to share with you the final diagnosis?
Yeah, go ahead, let us know.
So since she had signs of simultaneous immune thrombocytopenia purpura and autoimmune hemolytic anemia, we treated her for Evans syndrome. However, we did not find any obvious trigger. And what we did was transfusing her unit of platelets and consulting the hematology. And she got better in a week time, and we discharged her as her lab values stabilized. But yeah, she's been followed up right now.
That's such an interesting case, Bea. Thank you so much for presenting. Yeah, the thing that was bothering me was, the platelets of 8. I was like, that is like almost like ITP range. I think about like TTP often presenting with, platelets that may be less than 30K, but oftentimes you don't have like such a severe thrombocytopenia. So, I think like Evans syndrome makes sense if you're worried about both. And I wasn't even thinking about that. So I was like very much wanting to explain it all by one syndrome. That was just like, oh, is it like ITP? Maybe it's just a different presentation of a MAHA. So that is fascinating. Thank you so much, Bea. Any reflections, any other things that you learned that you want to share with us?
Nothing in particular. Just wanted to add that I have seen platelets going to 1,000, 2,000. I was shocked, but these things like happen very frequently. That's pretty much it. The only other thing is strange, we didn't find any trigger because I was told that Evans syndrome may happen after a trigger, like for instance, after a viral infection, but this was not the case, at least not that we thought, not that we found anything.
Yeah, no, yeah. It gets quite complicated. And, with the death and thinking about like autoimmune hemolytic anemia, she had like schistocytes. She's not really that anemic as well. So I think it's like such a fascinating presentation. Learned a lot. Thanks all. All right.
Thank
Yes.
you.
Do you want to take us home?
Of course. Thank you, Bea, for this amazing case. Actually, I hadn't known that it was Evans syndrome. And again, thank you, Dr. Sharmeen, for this discussion. Now, for the teaching points, we start with blood urine in a female patient. We have to think, is this the origin, vaginal origin, or are there stones, tumor, or trauma? Now, when we have dizziness and hematuria, we have to look for the source. It could be retroperitoneal. So we can think about screening and CTs. Just look for where is this patient bleeding. Now, look for signs of coagulation disorders if the patient has easy bruising, gingival bleeding, and in this female patient, menstrual abnormalities. Remember that a urinalysis with gross hematuria can cause wrong reported markers. We can have like false nitrates, false readings. And when we're talking about isolated thrombocytopenia, we can think if it's a structure of platelets or it's an intrinsic platelet defect or a bone marrow issue due to low production. We can think about hemolysis if there are schistocytes and BS. About heat, but this patient was not on heparin, although we can consider that. ITP is a diagnosis of exclusion, and also remember infectious causes that could be toxins or sepsis. Now, hyperbilirubinemia schistocytes can make us think of MAHA. We thought DIC versus TTP versus HUS, and will be helpful to know if the patient has had a history of diarrhea, since E. coli can cause HUS. We can think about asking for an Adams 13. And finally, we got to the diagnosis of Evans syndrome, which again, I was not aware of this. It can be a bicytopenia. Like I for what I have been reading in this moment, it's an autoimmune condition that presents with 2 or more cytopenias, which commonly includes autoimmune hemolytic anemia and immune thrombocytopenia due to warm IgGs that react to RBC surface antigens. And for the thrombocytopenia is because there's antibodies against GP2B3A on the platelets. So that would be it for today. Again, thank you for this case, Bea, and thank you for the discussion.
Yes. Wonderful teaching points. Thank you so much, Bea, for presenting. And Yusuf, you're awesome for both contributing to the chat and scribing at the same time. Thank you everyone for your thoughts and for being here. We'll see you soon. Bye.